is the most prevalent leukemia, accounting for approximately 30% of all leukemia in the Western blot. First of all, I want you to advise or to tell you that in Argentina, the Argentine Society of Hematology is working very hard in taking the final results of the register that is going on in Argentina. The median age at diagnosis is 72 years. Following diagnosis, most patients are monitored through a watch and wait approach, and therapy is not initiated until symptoms develop. Here, we in our country, we follow this initial personalization of treatment in older chronic lymphocytic leukemia patients. The decision is made in these early patients in the interaction of disease, age, and therapy, since aging involves a progressive decline in functional reserve and greater comorbidity, which combine to reduce life expectancy. So in this slide, the decision is influence the patient's life expectancy, the functional reserve, their treatment goals, an account of the disease, aggressiveness, effects on survival, effects on function. So we have finally the decision. Thank you very much. Thank you. The decision of treatment with effectiveness and less toxicity. Well, everybody knows these standard tools to evaluate the fitness of the patient, the functional, the comorbidities, and the quality of life. The best tool for assessment the physiologic age is this comprehensive clinical geriatric assessment. As you know, includes the function, the polymorbidity, the polypharmacy, the cognitive screening, the nutritional screening, the depression screening, and the socioeconomic resources. So, in Argentina, also we follow these standard indications for treatment initiation for chronic lymphocytic leukemia. So this is applied also for the young and for the elderly patient when they are symptomatic. If we have evidence of progression, the bone marrow failure, if we have a massive splenomegaly, the lymph nodes are more than 10 centimeters, the progressive lymphocytosis, the cytopenias autoimmune is the presence of these symptoms like unrelated weight loss. We know the night sweats, the fever. So we follow this. Now, determine the goals of treatment for older patients with CLL. We have to consider the reduced organ function, the life expectancies, and related to CLL, the comorbidity, the performance score. So if we have a patient with a long expectancy of life, with no comorbidities, is a fit patient, or go like you want to obtain a deep remission. The goal of this remission is to have an MRD negative, and the priority is efficacy. In the other extreme, you have the patients that are no-go. So with that patients, we have not to harm them. So we use palliation that implies low toxicity. And in the middle is the balance of efficacy and toxicity. We want to attain a good response with a combination of efficacy and tolerability. Well, this is, in Argentina, the guidelines of the American Society of Hematology 2015. In advanced stage symptomatic patients with treatment indication without deletion 70p, Patients over 70 years old, go, we indicate bendamustine, rituximab. The other option, fludarabine, rituximab, because these are fit patients. And then you have in the last, chlorambucil, rituximab. For patients over 70 years old, no go. These patients are unfit. We use chlorambucil, dose adjusted with steroids. Can use rituximab, pulses of methylprednisolone with rituximab, or best supportive care. With a lesion of 70P, patients with good performance status, first, ibrutinib. Now, ibrutinib is approved in Argentina recently, so it's available for everybody. To lenalidomide, and patients also can have, if they don't get the ibrutinib, high-dose methylprednisolone plus rituximab in patients with regular performance status with a lesion 70P, first ibrutinib. Now I want to share with you this communication, this presentation that was doing in the Argentine Congress of Hematology 2015. Is all the authors. Ibrutinib monotherapy in relapsed refractory chronic lymphocytic leukemia, Argentine experience. Introduction. CLL is considered an incurable disease, and most of the patients relapse after initial treatment. Frontline therapy for patients go is fludarabine, cyclophosphamide, rituximab. For patients over 65 years old, bendamustine, rituximab. For low-go, chlorambucil combined with anti-CD20 monoclonal antibody. For patients who relapse after response duration more than 24 months, retreatment with previous chemoimmunotherapy should be considered or switch to ibrutinib idelalisib. Well, everybody talks about ibrutinib. It's very important that it inhibits the Bruton tyrosine kinase and inhibits the proliferation, survival, adhesion, induced blocks the cell migration. Which is the objective of this study? To evaluate the response, efficacy, and profile of adverse events of ibrutinib monotherapy for relapsed refractory CLL. Material methods. Ibrutinib 420 milligrams monotherapy in relapsed refractory CLL. 7 centers in Argentina participate in this study. Follow-up between August 2014 until October 2015. We used the International Workshop CLL 2008 for evaluating the response. Only patients receiving ibrutinib during at least 12 weeks were considered for evaluation. Well, here you have the patient characteristics. You see the median age, 78 years old. Well, we performed the FISH, the lesion 70P, 30%, the lesion on 13Q, 13%, patient previous treatment median is 4 patients with fludarabine 75, we rituximab 88, median months from frontline until ibrutinib 19 bulky more than 5 centimeters, 38% response. The median duration of treatment with ibrutinib, 7 months, range from 4 to 13 months. Response. Overall response, 100%. As you see, 8 patients. I want to establish that 8 patients entering the study. CR, 13%, 1 patient. PR with lymphocytosis, 87%, 7 patients. Adverse events, toxicity, edemas, grade 1, only 1 patient, 13%. Rash, grade 1, only 1 patient, 30%. Anemia, 1 patient, grade 4. While here you have the value, the levels of hemoglobin, pre-ibrutinib, and last evaluation. You saw the increase in hemoglobin levels, also the platelets, pre-ibrutinib, last evaluation, the lymphocytosis, pre-ibrutinib, maximum value, last evaluation, and here the echo performance pre-ibrutinib. Pre-ibrutinib is in green and last evaluation is in red. You saw all the improvement in the echo performance. We use also the FACIT scale. The basal pre-ibrutinib, you see how high was the deficit, the functional deficit, and here a FACIT scale last evaluation. The conclusions. Ibrutinib as monotherapy in patients with relapsed refractory CLL obtained high response rates. 100% of overall response. We see PR with lymphocytosis 70 or 87 and CR 13%. Improve in cytopenia, platelets and hemoglobin, favorable toxicity profile, and treatment with ibrutinib show an improvement of the performance status and the FACIT scale. Thank you.
Okay, thank you very much. So, some comments. If I can I just ask you a couple of points? I noticed in your initial slides,
Yes.
when you mentioned the no-go patients,
Yes.
you put obviously chlorambucil, but you didn't put chlorambucil plus rituximab. Is that?
No, now we can use them also in this global patients. Like in Argentina, in my center, we participate in a clinical trial with obinutuzumab, now the treatment Gaziva, plus chlorambucil in patients with comorbidities. That was the clinical trial.
Yeah.
Now we can use also chlorambucil plus ofatumumab.
But not, you don't use it with rituximab also. But
Yes.
I saw it. Okay,
Yes.
maybe I saw it wrong. But I was surprised. And the other surprise I saw in a deletion 17p, lenalidomide.
Well,
First line.
well, no. First, what happened?
Did I read it wrong?
That was making in 2015. In that point, some patients cannot obtain ibrutinib because ibrutinib first was in Uruguay, not here. So the patients have to travel to Uruguay to buy ibrutinib or get as a consequence use. So we have, if you have not that, we try with lenalidomide with no good results.
Oh, not good. But I thought there was an indication by the society.
It's a suggestion.
Suggestion, okay. It's a suggestion, but
No, it's not approved.
that's not approved because that goes back to the issue of the on-label of label. And the second, just for my information, you have ibrutinib, but you never mentioned idelalisib. So in Argentina, it's
No. In
it's not-
Argentina, no.
not available yet.
Now, ibrutinib now is in the mid of January, 2016 is available. It's available for the patient with social insurance or the public from the government. Now the patients can afford and take ibrutinib here.
And the trial she showed was done with patients who got ibrutinib while still it was not approved in Argentina. So there was only a few
It
patients.
was
Who could
really
get,
a sacrifice for the people and for everybody to get the ibrutinib to go up with the trial.
Yeah. Carlos.
Well, I would like to make a comment, mainly because we are in Latin America. We cannot use this standard to classify the patients and no-go, go-go, and slow-go. We have, in my opinion, one more classification that I call social slow-go. That it's patients that it's not eligible to use fludarabine. People that live far away, no money to come quickly to a medical care. So this is not eligible to use fludarabine. And we cannot use, as you use, and I also, the American classification, the British, and the German classification. Our patients are different, and we can take in account in this. Otherwise, the patient will die due to the treatment.
No, Carlos, I think this is extremely important, but it's not only here. I mean, this happens in many parts of the world, not only Latin America. We always think of the lucky few, but lucky few. I mean, real life is very different. That's why I always, some people here know this. I always advocate the issue that chlorambucil is not dead, despite some friends in North America saying that they don't know the spelling of chlorambucil. I mean, but the fact is that it is used around the world a lot. And I always pushed Roche years ago to consider using much more the sub-Q formulation of rituximab. But in a real life, if you live far away, what you should be using is a pill. It could be ibrutinib if it was available in a different way, but anyhow, something oral plus a sub-Q rituximab. That's why I was asking if you were not using rituximab. Then if we had a sub-Q that could be done locally, that would be really great advantage for many patients who are just who can't get the new drugs, can't come to the hospital. I mean, there are practical issues, but not only in Brazil, which is very big, but even at home. If a patient lives 100 kilometers away and is 75, 80, 85, who's going to take this person to the hospital? These are real life issues. We can't forget, so it's easy to take a pill, and if you can get something sub-Q locally, that could change really management.
You know, doctor, in Argentina now we have rituximab subcutaneous.
But that is the Roche, but not approved.
Now. It's approved now, yes.
But not approved.
Yes, it's approved.
For CLL?
No, but
Not
in general, if you say about subcutaneous, in general, here is for lymphoma, follicular lymphoma, the subcutaneous rituximab.
But it's a big volume. There's still some complications. That's why a smaller volume would be very, 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 very important. I'm not saying this just by chance. I'm saying it for a good reason. So, Carlos, thank you for bringing that up.
And also, in real life, many old patients don't want IV
No.
therapy.
No.
So
There's also an issue of quality of
we
life.
We use a lot chlorambucil.
Absolutely. That's why the sub-Q rituximab will be very important.